Performing implant surgeries is not easy. It's challenging, requires a lot of experience and training. But I've been talking about this since years. You know, the fact that we cover too much of the clinical intraoral procedures. We don't plan the final outcome ideally, and we don't show the initial process to understand the ideal smile design in harmony with the face. So I always hoped that we could cover all three, because all three is very important. Understand where you want to be to start with, perform very well, and then show the realistic outcome. So how do you take the bite for these patients? Depends on what they have in the mouth. Okay, I'm going to give a quick summary here. The concepts are the same. The concepts are the same that we use for dentate patient. Of course, the dentate patient is a little better, a little easier, because you have teeth where you can put this anterior jig and allow the jaw to come into position and then register this position. Now, what we know is that CR and vertical dimension are two different things. The centric relationship is a jaw relationship, is not a tooth relationship. Centric relationship is a jaw relationship that is guided by the muscles and the TMJ. So somehow, to register the centric relationship, we need to take the teeth out of the game. Every time we touch one tooth lower against one tooth upper, our brain gets messed up and confused, and then teeth get control of the movement, and we lose the possibility to understand where muscles and TMJ would take the jaw. We're going to talk about this more on the functional rehabilitation, the bite lift lecture. Then the vertical dimension. So how can you take, how can you find this jaw relationship when patients don't have teeth? The vertical dimension, on the other side, is much more related to the occlusion relationship, the teeth. We want to allow the teeth to be interacting with each other, following the principles of occlusion that we learn: overbite, overjet, space on the back, inclinations, guidances, working side, non-working side, equilibration of context in both sides, and so on. So it's much more, it's a tooth-driven decision. CR is a muscle TMJ decision. Okay? So hopefully when you take the CR, we also bring a convenient vertical dimension for the teeth. This is the two things that we want to bring. So in edentulous patients, we still many times have to work with the wax rim. If your patient has no denture whatsoever, very few remaining teeth. Remaining teeth have perio issues and are moving all around. It's a problem. You cannot make a registration with just a few perio teeth in the mouth. You cannot make a registration if the patient doesn't have a denture. It's living without teeth. You cannot have a proper registration if the old denture is so old and so destroyed. That is also not a decent starting point. So I showed these slides for you before. The process of designing an aesthetic functional smile. First, we design the upper against the face. This is no problem. Then we need to bring the jaw relationship. Then we need to fine-tune the vertical dimension for restorative convenience. After that, we can design the lower against the upper, and then we check the movements of the jaw. So CR is here, and OVD is there, so they're kind of coming together. If you have an edentulous patient with a wax rim, first step is pretty easy, because you can scan the wax rim, you can scan the ridge, you can take the pictures of the face, and we can overlap the information. Look at that. And instead of doing a denture setup like an old school denture setup, right? we will mount the teeth digitally over the wax rim. So what is the advantage of the digital against the analog? In the analog workflow, you need to be very good shaping the wax rim in the mouth, because whatever you shape in the mouth is what your lab is going to follow. In the digital environment, you don't need to worry about a perfect wax rim, aesthetically speaking. It can be wrong, because we will do the lines on the computer, and we're going to set up the teeth according to the lines, not according to the wax rim. Okay? So all of this is unnecessary. You don't need to do this. You don't need to shape this perfectly. We just need something in the mouth to be able to take a picture, support the lip closer to ideal, and then we can design according to the lines. Why you don't need to make a perfect wax rim? Is it clear for everybody? Of course that it cannot be somewhere that the patient is like, it's so wrong that the patient's face is distorted, right? It needs to be something that is there for the pictures. And then you scan the wax rim, and then we can do the design according to the guidelines. So you see, my tooth setup is not following the wax rim. It's following the guidelines from the software, everything that we talked about the last few lectures, okay? So this is, and then the other thing, we can test the design in the face in the computer before sending anything to the doctor, in all different angles, all the DSD views, occlusal view. We make the upper design very nice according to the facially driven principles. Now we need to register the jaw relationship. So now the wax rim needs to be very good, because for aesthetics, the computer will overrule the wax rim. But for the vertical dimension and the jaw relationship, the wax rim is gonna give the information to the computer. Okay, so you need, on these cases, to practice the same thing that old school denture guys have been doing since ever. Checking the face and learning how to manipulate this to get a nice facial proportion and a nice mandible position. Okay? As soon as you have that, you scan. Exactly like teeth. And that's what we need. So you scan, and then we can bring the vertical dimension to the software. Okay? And then we can wax the lower. So we swap on the computer, we take the wax rim and we bring the teeth, and you have the upper lower functional aesthetic design in 3D. This is the moment on the previous case that I showed from my brother Francis with the thinking process. This is when he realized that there was a bone issue and he changed the design. So what we can do here is that we can go back to the virtual articulator and change a little bit the vertical dimension. So start with the wax rim upper design, wax rim on the lower vertical dimension, and then integrate the upper and the lower. If you have teeth on the lower, you don't need to do, of course, the wax rim in the lower. You're going to ask the patient to bite the lower against the upper wax rim on the same vertical dimension that you want and scan. Upper wax rim, lower teeth. Okay? And then we're going to test the movements in the 3D software. Okay? We can print a prototype, as you see here. And then prototype is in the mouth to check the occlusion and check the aesthetics. Okay? So what we want is to make sure that this is well done, because this will respect this. When you place the wax rims in the mouth, if by any chance you don't melt enough, you don't soften enough the wax, that the patient needs to put pressure to squeeze the wax rim, and as they put pressure, the jaw slides a little bit, then everything is off. What is going to happen is that you're going to go all the way to this expensive full zirconia bridge, and the patient will be forcing to bite, and probably after a few months the jaw will try to go back to the best position and will destroy your prosthesis. Okay? So that's why the prototypes are nice. Cheap printed prototypes on these cases, I strongly suggest. Because you can screw the prototypes in the mouth before you mill the expensive zirconia, and you can have the patient open, close, and you can see if they're comfortable in that position. Okay? So just a couple of examples here. Teeth and teeth. No change on vertical dimension. Easy. Ask the patient to bite, scan the bite, design the restorations. Teeth and teeth, but you decide to open the vertical. You need an appliance, a deprogrammer, anterior jig, scan this new position, design the outcome. Teeth and teeth. A lot missing here. This is tough. You know, you need to see if there's enough here for you to hold an acrylic jig here as an anterior jig. Enough. You know, sometimes this is all moving because it's perio, completely gone. So you can splint this together, make a jig, or you create an appliance on the lower with wax, and you ask the patient to bite together. You have the vertical jaw relationship, and you design. Patient already has existing implant bridges, but the vertical and bite is completely off. No problem. What do? You can do a wax bite or a silicone bite. You need to manipulate. You can put a jig in the front to open the space, and then fill the back with occlusal material, and then scan. This is what we really need. This is what is important. This file here. Okay, so we need to trust this file. Patient has old dentures, removable dentures, but they're pretty good. Vertical is not bad. You just ask them to bite and you scan. No problem. And you use this vertical, this jaw relationship, to design the new prosthesis. We are moving from a removable to an implant supported, but the existing removables are not bad in terms of jaw relationship and vertical dimension. Similar situation. Removable, but the removable is old and the patient lost vertical dimension. So then you need to use some kind of bite registration material, manipulate the jaw, or use an anterior appliance here, right, to open the bite, as you see here, open the bite, and allow us to design the new with slightly more space, so it's better facial proportions. The one you saw here, if the patient has nothing on the upper, no old prosthesis, then there's no way. Wax rim, bite lower against the upper, scan everything, design. And both Edentulous we saw right now, you need to find the vertical and the CR position with the wax rims. Okay?